Hello again from the embryology laboratory of Dr. Sterev Hospital. I'm Tanya Milicic and I'm going to present now, and for me it's a great honor to be here with us, John Stevenson. John Stevenson is a consultant physician and endocrinologist at the Royal Brompton Hospital, London, reader in metabolic medicine at Imperial College of London, and visiting professor in Belgrade School of Medicine. He has clinical expertise in menopause, HRT, coronary heart disease prevention, insulin resistance, cholesterol problems, calcium problems, osteoporosis, metabolic bone disease, thyroid disorders, and a lot of general endocrine problems. He has over 450 scientific publications, including 11 textbooks. He is an active member of several scientific societies, and he served on various committees and editorial boards. Now it's your time to present long-term problems of premature ovarian insufficiency. Please, Professor Stevenson.
Yes, thank you.
Okay. Let me just put it onto slideshow then. So I'd like to thank the organizers for asking me to speak. Sorry about the hesitancy there. I'm sorry that I can't actually be with you in person, but this is what happens in this day and age. So I'm going to talk about premature ovarian insufficiency. These are my disclosures. So if you look at premature ovarian insufficiency, there are long-term consequences of this, and some of these are highlighted here. Cardiovascular health, bone health, genitourinary health, and neurological health. And what I want to concentrate on today is cardiovascular health, particularly coronary heart disease, and then very briefly, osteoporosis. So if we look at the effect of menopause on coronary heart disease, this is a study of 10,500 postmenopausal women, natural or surgical, with no prior coronary disease. And what you can see from this slide is that women with premature ovarian insufficiency, having their menopause below age 40, have got double the rate of coronary disease compared to women having a menopause above the age of 45. So we know that menopause is a major factor for coronary heart disease. And that's because menopause induces many adverse changes in metabolic factors. And over 20 years ago, we published a paper suggesting that the menopause results in a metabolic syndrome with adverse effects on lipids and lipoproteins, on glucose and insulin metabolism, on body fat distribution, blood pressure, and coagulation and fibrinolysis. And it has been shown that perhaps 50% of cardiovascular events in women are related to the metabolic syndrome. So what are these changes? Well, when we try and reverse the menopause with hormone replacement therapy, then we can reverse many of the adverse effects, so that hormone replacement results in a decrease in total cholesterol because you get a decrease in LDL cholesterol. You may get an increase in HDL cholesterol, which is beneficial, but that is often at the expense of an increase in triglycerides. Or depending on which progestogens you're adding, you may get a decrease in triglycerides, but that will be with a decrease in HDL. And there are other advantages with HRT. You get a decrease in lipoprotein little a, which is good. You get an increase in the clearance of the more atherogenic lipid particles, the small dense LDL particles, and the postprandial chylomicron remnants. And there's probably a decrease in oxidative damage to LDL. So these are all the good things that HRT is doing to lipids and lipoproteins. In terms of the effects on insulin resistance, then oral estradiol improves insulin resistance, whereas low-dose conjugated equine estrogens really have very little effect on insulin resistance. At high doses, the conjugated equine estrogens can actually even worsen insulin resistance. Transdermal estradiol has a small effect on improving insulin resistance. The progestogen is very important because if you add an oral androgenic progestogen, this makes insulin resistance worse, whereas the non-oral and non-androgenic oral progestogens, such as micronized progesterone or dydrogesterone, really have little or no adverse effect on insulin resistance. And if you give even androgenic progestogens transdermally, they seem to have very little effect on insulin resistance. Now, we use HRT for the treatment of premature ovarian insufficiency, but people also will use oral contraceptives, and their effects on the cardiovascular system are not as good because the oral contraceptives raise triglycerides, they tend to increase insulin, they increase coagulation activation, increase vascular inflammation, and may result in adverse vascular remodeling. So certainly there are big advantages of HRT over the combined oral contraceptive in this respect. Estrogen has very important effects on arterial function, and estradiol will restore nitric oxide dependent endothelial function, increase nitric oxide synthase production, and it reduces the endothelium 1 release. Endothelium 1 is a very potent vasoconstrictor. Nitric oxide, of course, is a very potent vasodilator. So these actions are very good, they're vasodilatory. Estradiol also inhibits calcium channels and enhances potassium-dependent channels. And again, these are vasodilatory actions. And in very simple terms, I always say that a dilated artery is a happy artery. Estrogen will reduce angiotensin converting enzyme activity. It reduces vascular smooth muscle cell proliferation and probably improves vascular remodeling processes. So these are going to be good in terms of atheroma development. Let's just look now at a study from my colleague Marco Gambacciani in Pisa in Italy, looking at the effect of estradiol or estradiol plus the addition of dydrogesterone on arterial function. And so he's looking at hyperemic response on the left-hand side here and flow-mediated dilatation on the right-hand side. And what you can see is that the estradiol improves the hyperemic response and it improves flow-mediated dilatation. When you add the progestogen, the dydrogesterone, there is absolutely no adverse effect on this estrogen effect on the arteries. This is a small study of women with premature ovarian insufficiency looking at endothelial function, and they were treated with conjugated equine estrogens, 0.625 milligrams, plus cyclical medroxyprogesterone acetate. And this was over a 6-month period looking at hyperemic responses. And this is showing flow-mediated dilatation. This is baseline. And after 6 months, you can see a significant increase in flow-mediated dilatation. So an improvement in endothelial function, just as we saw in the previous study that was on normally postmenopausal women. If we now look at what happens in women having a normal menopause, for most of the data we have, because we've got so little data on premature ovarian insufficiency, we have to look at the normal menopause. And these are data from the US Women's Health Initiative study, the estrogen alone arm. And what you can see is that initiating HRT below the age of 60 gave a non-significant decrease in myocardial infarction or death, but a significant decrease in coronary interventions. And if you combine these two as a composite outcome, there was a significant decrease. Whereas the women starting the HRT between the ages of 70 and 79, compared with placebo, there is absolutely no effect at all on any of these outcomes. But there is no worsening of the outcome, but there's just no improvement. And of course, with long-term follow-up of the Women's Health Initiative, those initiating at the HRT below the age of 60 showed a significant decrease compared to placebo in coronary events. So this is showing quite clearly that you can get benefit for coronary heart disease from HRT. Another study here from Denmark, the Danish Osteoporosis study, looking at over 1,000 women aged between 45 and 58 years. And these women were on average just 7 months post-menopause, and they were randomized to either estradiol alone or with the addition of norethistron acetate or no treatment. The trial was stopped after 10 years, but there was a further follow-up observationally for 6 years. And they looked at a composite outcome of myocardial infarction, death, or admission to hospital with heart failure. And you can see that there is a significant reduction in this outcome with the HRT. Interestingly, they showed no increased risk of stroke, venous thromboembolism, or any form of cancer, including breast cancer, with the HRT over the 10 years trial and the further 6 years follow-up. This is a Cochrane review, a meta-analysis looking at randomized clinical trials of HRT versus either placebo or no treatment. Nearly 32,000 postmenopausal women were included in this study, and they were exposed to HRT for up to 10 years. And they divided the women according to the initiation of the HRT within 10 years of menopause or beyond 10 years of menopause. The outcome was cardiovascular death or non-fatal myocardial infarction. And what you can see is that for those women initiating their HRT within 10 years of the onset of the menopause, there is a significant reduction in coronary events compared with placebo. For those women initiating the HRT beyond 10 years post-menopause, they did not show a reduction. However, I would stress they did not show any increase, so there was no harm. We just didn't see the same benefit. And here's a study from Finland. This time the outcome is coronary heart disease death. And these are data from the Finnish National Register. Over 90,000 postmenopausal women in this study with HRT exposure up to 9 years. And they divided the women again according to the age when they initiated the HRT. So those initiated below the age of 60 show a very significant large reduction in coronary death, whereas women initiating their HRT beyond the age of 60 show a non-significant reduction. So again, no harm, but this reduction is not significant. If we look at the effect of oral contraceptives on myocardial infarction, then in contrast, you can see that the studies tend to show that there is an increase at risk of myocardial infarction, albeit very, very low. And these are with all the different combinations of ethinyl estradiol and various progestogens. Of ethinyl estradiol, again, there's still an increase in myocardial infarction. So clearly there is a big difference in terms of coronary risk between giving HRT and giving oral contraceptives. But I would point out, of course, that the oral contraceptives here are being given to healthy premenopausal women. These are not women with premature ovarian insufficiency, so they are not estrogen deficient women. They are women with normal ovarian function in the first place. And this may make a difference. We don't know what the effect of oral contraceptives will be in terms of myocardial infarction in women with premature ovarian insufficiency. Let me just quickly now turn to osteoporosis, and many studies have shown that HRT will prevent postmenopausal bone loss. This is one of our early studies showing that both transdermal HRT or oral HRT result in an increase in bone density in postmenopausal women compared with untreated reference groups showing postmenopausal bone loss. We know that there is a good dose response curve, which as we showed in this study, and that even with oral estrogen, perhaps doses as low as 0.5 milligrams are still going to have a beneficial effect in terms of bone density. And the Women's Health Initiative did show us that in terms of fractures, that HRT is very effective in reducing the classical osteoporotic fractures. Even though this population was not an osteoporotic population, there was still a significant reduction in hip fractures, in spine fractures, and in total fractures. We really have very little data for premature ovarian insufficiency in terms of fracture outcomes. However, we do have data on bone density. And I want to just show you this slide. This study is from Beth Cartwright and Janice Reimer in London, where they're looking at a study of premature ovarian insufficiency in 59 women aged between 18 and 44. Of these women, 29 opted not to have any treatment, so they acted as untreated controls, and the other 30 were randomized to either HRT or a combined oral contraceptive. And the HRT consisted of 2 milligrams of oral estradiol together with cyclical levonorgestrel 75 micrograms. The oral contraceptive was ethinyl estradiol 30 micrograms and levonorgestrel 150 micrograms. And this was a 2-year study. And what you can see on the chart here is that there was a significant increase in bone density with the HRT, and this was significantly better than with the oral contraceptive that showed just a small non-significant increase. And in the hip, again, although these changes were not significant, clearly the HRT is looking better than the oral contraceptive. But we don't have big studies to look at fracture incidence in these populations. If we look at the effect of premature ovarian insufficiency on mortality, this was a study of premenopausal women, 1,300 with a unilateral oophorectomy and over 1,000 with bilateral oophorectomy, and 2,400 controls. And looking at all-cause mortality, if you look at bilateral oophorectomy below the age of 45, then there is a significant increase in all-cause mortality. So it clearly is crucial that we treat women with premature ovarian insufficiency. And we can show that with HRT, this is again in women with normal menopause, then looking at the women HRT versus placebo or no treatment, this is the Cochrane review again, and those women initiating their HRT within 10 years of onset of menopause have a significant reduction in all-cause mortality, which is not seen in women initiating HRT beyond 10 years post-menopause. Again, no worsening, no increased risk with the women initiating beyond 10 years post-menopause, but you don't see the same benefit as you do in those initiating within 10 years of the onset of menopause. So, in conclusion, what I hope I've shown you is that premature ovarian insufficiency increases both coronary heart disease risk and osteoporosis risk. And I believe that the totality of the current data we have indicates that HRT is beneficial for the prevention of coronary events. And this is largely in women who've had menopause at a normal age. But I believe that it is almost certainly true for women suffering from premature ovarian insufficiency. We know that HRT is very beneficial for the prevention of osteoporosis. And again, I believe that this was true for women with premature ovarian insufficiency. In terms of coronary heart disease, the benefit will depend very much on the type of hormones that are given, particularly the progestogen, where the non-androgenic progestogens really should be preferred if possible. The dose of the hormones at initiation is important, depending on the age of the patient at initiation of therapy. And obviously for women with premature ovarian insufficiency, then the dose of the hormones is not quite as important. We can give them the usual standard doses. But I believe that HRT is actually preferable to the oral contraceptive for the treatment of premature ovarian insufficiency. But some women will prefer to take the oral contraceptive, and it's quite likely that that will give benefit rather than them having no treatment at all. And we should always try and offer treatment to all women with premature ovarian insufficiency in order to prevent these long-term consequences that will otherwise result. Thank you very much.
Thank you very much, Professor Stevenson. Are there any questions from the audience, please?
Unfortunately, there are no questions in written in the chat room.
So I can comment only that it was a very interesting presentation that lead us to more knowledge about hormone replacement therapy, which is very beneficial for prevention of coronary heart disease and osteoporosis for a patient with poor ovarian insufficiency. And also what I have learned is that if we start earlier with HRT after menopause, also the mortality will be less. So thank you very much. It was very interesting for me.
Thank you very much for asking me.
Hi, thank you very much for our lecture. Very interesting and good example for the for use of HRT. But my question is, what about the treatment with statins in perimenopause age?
Yeah, the problem with the statins is that they have not been shown to reduce coronary mortality in women as they do in men. So they're not really as effective for women. Having said that, of course, women who have got coronary heart disease will benefit from statins, and those with hypercholesterolemia, we can always consider them, but they could be in addition to HRT rather than in place of HRT.
Thank you.
Hello, nice to meet you. Thank you for the perfect presentation. My name is Dr. Sal Petrov. I wish to ask how long should we continue with the HR therapy? Thank you.
Thank you. That's a very good question. One to which I don't think anybody has an answer, because we just don't know how long we should go on with the HRT. But I would say it would need to be a minimum, I would think, of about 5 years. There is some evidence to show that giving HRT for a few years around the time of menopause will translate into a benefit in terms of reduction of coronary disease at least 15 years later. But really, we have very few data on this. And I would say the longer you can keep the patient on the HRT, the better the outcome is going to be. So I'm a great believer in long-term use of HRT.
Thank you, Professor Stevenson. I would like kindly to remind the audience that you could ask your question in written form in the chat session. Now we have a 30-minute break, and we're expecting you back in 11 o'clock. Thank you again, Professor Stevenson.
Thank you.
you.
Thank you again. I'm closing the session. Thank you.